Okay. So, I mean, this is a slide which pretty much every person in vascular surgery is familiar with. It's been beaten to death, the task A classification, but it certainly gives a uh, background that you can kind of talk about in terms of what is simple and not so simple. And it's kind of a basis for a discussion and maybe a comparison between things. So we look at some cases in each of these groups. I'm not going to specify it as A, B, C, or D as we go along, but kind of the complexity goes on as we go along that lines. So I mean, you could. So task A and B, like the previous picture you saw there, nice narrow stenosis, unilateral, not much of problems. So the question is it just a plasty, a primary stent, or a selective stent? There's been enough studies done on this. So like the big one was the Dutch iliac stent trial, looking at the results comparing definitive stenting versus elective stenting if somebody had a more than 10 millimeter pressure gradient. And this was looked at by clinical success. And clinical success, patency, reintervention rates at 2 years was similar, but at 5 to 8 years, you actually had a better clinical outcome in patients with angioplasty and selective stenting as against a mandatory stenting. So I think what it means is, especially in a poorer country like ours, it is fair to only do an angioplasty for an iliac lesion if a stent is either, if you don't think it's required, that's fair enough. And of course, if you think there is a financial constraint, I don't think there'll be too much criticism if you not use the stent over there. This is the outcomes, again, theoretical. So you can see that there is a difference when you look at the 5-year rate especially. Now, should you use a self-expanding stent or a balloon expanding stent? So not that many trials on this, but when you look at the randomized ICE trial, which was the one in 2017, reasonable numbers of patients, basically looking only at the common iliac artery, 16% occlusions, which is fair enough, heavily calcified, which is 27%, which again is quite common with what we see. And when you look at the restenosis and the target lesion revascularization levels at 12 months, you find that the self-expanding stents are performing clearly better than balloon expanding stents. Now, this is slightly different from what we have traditionally been taught or have been teaching, that when you're near osteal lesions and for the proximal CIA, that is often an osteal lesion where you want accuracy, a balloon expanding stent is what is preferable. So there appears to be a trade-off between balloon expanding and self-expanding stents, between accuracy of deployment, which is important in lots of situations, and the trade-off in terms of revascularization staying open down the line. Covered stents, the famous COBEST trial, which we talk about always. So when you look at primary patency, even at 5 years, there's really no significant difference between both the groups, bare metal versus covered. Secondary patency, again, between bare metal and covered, there is no real significant difference at 5 years. When you start looking at the subgroup, task C and task D, the covered stents do better in terms of primary and secondary patency compared to bare metal stents. So task C, task D are the more complex, the longer lesions, the ones that are occluded. Those are the ones where the covered stent shows greater benefits. So twofold higher incidence of reintervention in the bare metal group compared to covered stent group. One other interesting takeaway is 20% mortality over 5 years. So this is probably not, it's definitely not a reflection of the iliac stent, but rather a reflection of the fact that this patient group is not the healthiest, and we know that. But this is again Western data where patients are typically older than us. And when you look at a twofold higher incidence of reintervention, the incidence of reintervention itself isn't that very high. So yes, there is a benefit to covered stents. How relevant is it in clinical terms for some of our patient populations whose expectations and ability to afford this is limited? Is something you have to keep in mind when you decide how you're going to, what kind of a stent you're going to choose if you're going to stent. So this we will come to later on. So I'm now going to switch to a different window, and we'll look at some of the procedures we have done here. Okay. So we'll try to go through these angiograms. So this is a think, how old was it? A 62-year-old chap who basically had left leg claudication, fairly flow limiting, lifestyle limiting, with a weak femoral pulse and nothing else palpable distally. So he has an angiogram. Now, when you want to do an angiogram and you're suspecting an iliac lesion, normally you would have done, ideally, if you're looking at aorto-iliac disease, you should have a CT scan before you intervene on that, a CT or an MR, so that you know what you're dealing with. Between the two, I prefer CT scans because this shows you calcification and it shows you atheroma, it shows you other things, which is very helpful for deciding what you need to do, how you need to approach, what hardware you need to have, and what kind of complications you may face. So in this case, we have chosen to go with a crossover approach. And the reason for that was because this gentleman also had left-sided SFA disease. So with a crossover, you can deal with the iliac lesion and the SFA at the same time, which you would not be able to do with a retrograde, of course. And on the angiogram, what you can see is that he's got this, it's not seen very clearly here, maybe the next one is slightly better. So this is what's happening when you're crossing over, your wire goes into the, and sheath goes into the opposite internal iliac, which is where it typically wants to go by default. So you need to maneuver your way back into the external iliac artery, which is what is interesting you. So these were the distal runs, and you can see the SFA is calcified. And right down in the near the P2, P1 junction segment, there is a tight stenosis over there, which explains why he's having so much claudication despite just what is a relatively trivial iliac lesion. So if you see a trivial lesion and you're seeing somebody with significant symptoms, you should assume there is another level of disease and you need to go looking for it. And in fact, when you look at this one, what he's actually got looks like a bit of clot that is hanging there from a bit of plaque. That tongue hanging there is typical of a clot. And this is one I would be careful about while trying an angioplasty. You're worried this will trash down and take out your distal flow. So we can ignore that, and going back to the iliac, yeah, so it's a crossover, and when you're doing a crossover, the most useful thing is get a crossover sheathing. And if you look at the sheath, maybe you can see better in this picture. Yeah, you can see the markings on the sheath. This is a braided sheath, and it has got a radio-opaque tip. Both things which are very useful. So the radio-opaque tip shows you where you're reaching. The braided sheath allows the sheath to cope with turns and crosses and all of that, and does not kink. If you use a simple non-braided sheath, especially in an iliac bifurcation, which is like a sharp V or an A, you're very likely to get a kink in your artery, in your sheath, following which your wire will kink, following which nothing will track over it. So if you want to do crossover procedures, have a crossover sheath available. The Cook sheets are very good. The arrow sheets are good, but what you want is a crossover sheet. And the length you would look at, so crossover sheets in Cook are typically 40 millimeters onwards in their start, which is good, 40 centimeters onwards where they start, which is good. For some procedures, we will even use a 90, but that's when I come transbrachial, we look at that. But yes, if you want to do aorto-iliac, you really should have a selection of 6 and 7 and preferably even 8 French crossover long sheets available to you. Wire-wise, once you cross over, you want a stiffer wire. So you may choose to cross using a glide wire. But once you got your glide across, best to get a catheter down, exchange it for a stiffer wire like an Amplatz, which you can see with the curve here. There's another wire which I'm very fond of for aorto-iliac, which we'll come to later on. But yes, you do want a stiffer wire if you want to exchange your crossover sheath over there. And especially if it's an aux sheath, I think you're generally better off with a stiffer wire rather than with a glide wire. So sure, once you've got this in place, do your angiogram. So here, obviously, the contrast is flying away too fast. So simple angioplasty being done with a balloon here. This was an 8 millimeter balloon. It was actually a stent balloon that was used, an 837 balloon. You do your check angiogram, and you can see the internal iliac coming off there where it overlaps. The stenosis is opened up fairly well. Don't need to do much more. Take an angiogram in a slightly different projection. Make sure there's nothing else going on there, that you're happy with the flows. And that was it done. The SFA lesion was dealt with surgically in that case, is what we chose to do in that particular patient. And this is a nicely opened out view. So we are looking at the iliac in multiple projections after you do this because of a concern of rupture, which is actually very less in a lesion like this, but there is a concern. And if you look at this image, you see the luminogram here, and you see this little bit of streak of contrast that is kind of outside. That's something that you would want to watch and make sure that is not an area of a contained dissection. All right, so this was just a simple, straightforward task, a simple balloon angioplasty. Had a good result. So you're going to look at the next one. So this chap looks very straightforward, has got right-sided claudication on the angiogram, which I don't remember why, but we chose to do a bilateral puncture here. He's got a fairly tightish lesion over there in the right common iliac, and he's symptomatic with a dampened pulse. So on both, whether you inject retrograde or antegrade, you can see that. So get a wire across, looks fair enough, and it looks like a good position to be in. And decision to go for a primary balloon-mounted stent over here, common iliac artery. So it's being done on a smart mask. So you can see that being very careful to deploy the stent within the constraints of the common iliac artery and cross the lesion and stay short of the internal iliac if we can. So on a smart mask, and you can see it's a tight lesion. Pops open. So do an angiogram. Looks nice. Except when you look at that, you see a streak of contrast appearing late over here. So do one plain X-ray, are you seeing any contrast outside the confines of your stent? Is there any holdup of contrast that suggests that you're worried about something? We don't see that. Do another angiogram, you're still seeing that. And one more, you still see it. And on this projection, it's not seen quite as visibly. And when you're doing this, you're certainly watching the patient's hemodynamics. Now, another angiogram, this is being done a bit later. We're doing this at various time intervals. So the first one here was done at 15:23. This one being done at 15:30. So 7 minutes later, and there's been a balloon that's been left inflated during this time, but we're still seeing this. And now this is done at 15:33, still going on. And you can see this in the mag, it's fairly clear. Now, this kind of an image is something which you need to look for. So among the endovascular interventions we do for the lower limb, the aorto-iliac is the one segment where you can have a surgical disaster on table because of bleeding into the retroperitoneum. And heavily calcified iliacs, nasty iliac vessels, are the ones that you want to be most careful about. I have realized in life that I am not a lucky surgeon. Things can go wrong, they will go wrong for me. So I just respond to that by being extra paranoid. So look for this. And in this patient, we were not happy to leave it like this. Spoke to them, and we got spoke to the family, and we got another covered stent in to cover this area till we were happy that there is nothing happening. Okay, you can still see that blush outside, but now we know we are okay with what we've got here. So that's a simplish case which can give you trouble. So this gentleman had previously had a left-sided iliac stent done for him elsewhere and had come back now with right-sided claudication. So on the angiogram, he actually has, if you look at the image over here, he actually does have what looks like an in-stent stenosis. And whoever has done the stenting the previous time has completely jailed the right common iliac. And you can see the effect of neointimal overgrowth causing a tight stenosis on the right side. First step was to get a balloon inflated into the stent. And there is a stenosis there which opens up. This was just a simple POBA done here. Next was to position a stent on the right side. So this is where the right common iliac has been jailed. So a couple of things we had to be careful about while dealing with this. One is we did not want to go through the stent struts either on the left side or on the right side. So what we chose to do was on both sides, when we cross the stent, you go bareback, that is without the wire. So use a catheter, something like a vertebral or a 4 French pigtail, which will not go through the stent strut, but rather has to go through the larger lumen that is open. So that way you ensure that your wire is not slipped in and out of the stent struts on its way out. So we did that on the left side. Similarly, on the right side, to cross the lesion, again, we used a blunt catheter to go past the left common iliac stent struts that was sitting on the origin of the right common iliac. So that way you know you're out. Now, it is possible. You can do what's called a culotte technique, where you go through the stent struts and you angioplasty into that. But if you don't need to do that, you're better off not doing that. Next question is, what kind of a stent are you going to choose on this side? Now, we chose to use a self-expanding stent on the patient's right side, because the self-expanding stent continues to have an outward radial force which will stay in place even after we leave it in over there. And when we do this, we support it with a balloon on the opposite side. The stent is open, but it doesn't look so hot. The proximal common iliac still looks tight. So ballooning of that is done. And the way that balloon moved forward inflated does not look nice. It's not a good picture. Next, we balloon this after having deflated the left side stent. So we are accepting a partial deformation of the left common iliac artery balloon expanding stent. And we expect our right side self-expanding stent to keep the other stent displaced away from the orifice. And remember this, the left side stent probably has a degree of neointimal growth over there, which is causing a problem. When you look at the angiogram, you've got good flow going down both sides, even though the stents, frankly speaking, look quite ugly on both sides. But flow was restored without having to do much else. The other alternative, of course, was to reline the left side with another balloon, another self-expanding stent, and take them both higher up. But that's got cost implications. But if you can afford it, that's probably the better option. That both sides have got self-expanding stents with outward radial force, which will take care of what you're doing. So this guy was someone with bilateral lower limb critical limb ischemia. And so here is one of the things that I use very often, which is a left-sided transbrachial approach. So for patients who have iliac occlusions, or those who have concomitant SFA disease and who require intervention on both sides, I'm very liberal about using a transbrachial approach. Now, certainly with transbrachial, if you're using a 6 or 7 French sheath, be prepared that there is a not insignificant incidence of brachial artery thrombosis. So you should be prepared to finish off the procedure with a small cut down. Or else, if you want, do a primary cut down, expose the artery and work through it. We've also occasionally gone transradial. Transradial means you can't use larger diameter sheaths for interventions. And somebody who's tall, your sheaths, wires, and balloons are not going to be long enough for you to do everything that you want to do. So with transbrachial, there are certain technical things that you need to be careful about, which is specifically length. Remember, most of your catheters are 100 centimeters. Typically, your iliac bifurcation will come at approximately 70 to 80 centimeters. So you don't have too much length after that to work with if you're using a 100 centimeter catheter. The glide wire that most of us use, or most of our exchange length wires, are only 260 centimeters. So they run into length issues when you start reaching the distal CFA and beyond. Fortunately, balloons are long, they're 135 centimeters, so they give you more working length. But when you use a balloon, your wire falls short. So you've got to balance out all these things when you're working with transbrachial access. So this angio shows, I'm sure you can see that there is a tight eccentric plaque in the right common iliac. There is a occlusion of the left common iliac with a small stump, seen better over here. And you can see reformation of the left external iliac. So you've got a left common iliac artery occlusion. And here you can see left external iliac, and you can see the left internal iliac forming over there. So again, one of our favorite catheters that we use here to help us cross. So here we will often set up a biaxial or a triaxial system. More often biaxial than not. So you've got a long sheath which is able to come right down to the stump and park it in that. In that you get your wire in, and a catheter that we use quite often is the Rubicon, which is a support catheter. You can also use the Cook approach catheter, both of which are long support catheters that give quite a bit of stiffness. The problem is the Rubicon comes only in a straight configuration. The Cook one has got an angle also, which is useful, but it's more expensive. They are both 150 centimeters long, so they give you good length to work with. But when you've got a long catheter, your problem becomes your wire may not be long enough. So when that happens, we use a different wire. So here we managed to get through this occlusion, and you see these markings. This is on the Rubicon, and done an injection to confirm that we are intraluminal over there, which works for us. And here is getting a wire down, and the two wires that we use that are helpful here is, one is especially the Abbott Supracore, which is a 300 centimeter stiff wire, or the other wire which you have, which is 300 centimeters, is a 014, which does not give you great support, but it gives you the length you need, which is helpful when you're crossing remote lesions. Okay. And then certainly a preplasty as usual, and I always preplasty small. I mean, in the left common iliac, or in any common iliac occlusion, I have burnt my fingers enough times to know that I don't want overdilatation. That's not what I need. So we open it up. It's still tight despite the balloon there. That does not look nice. So we got a balloon to inflate that. Yeah, there's a balloon over there while these angiograms are being done to look at the right side. So doing a long plasty on the left. Got another wire in from that side. And plan here is to deploy a stent across this eccentric plaque. Balloon expanding stent, because we want accuracy, and that's it on both sides. We want accuracy. Both the stents are being lined up. Such kind of eccentric plaques, I'm always worried. When you put a balloon expanding stent, the plaque may not yield, and you might actually get the vessel might be rupturing when you do that. So be careful, be aware of problems that can happen. Stents on both sides, excellent flow running down, and you can see the internal iliac is also well preserved. We were happy with that. And then we went on and dealt with the left SFA, which we could do from the top. Streaky SFA, dealt with over there. But that's not part of what we're doing, so I will end this one here. So again, one of the, like I was saying, one of my preferred axes there. Left transbrachial. Now, you're all obviously familiar with this, but remember this. Often when you come left transbrachial, your wire will want to hook and go up into the left vertebrae. Be conscious of that, be aware of that. Don't just jam your wire in straight up. Make sure it comes down, and when you're crossing, always useful to go into a steep LAO position so that you can see that the wire is going down the left side and into the descending thoracic aorta rather than into the arch, which is where it preferentially wants to go normally. Now, if you look at this picture, this is typical of distal aortic occlusions. So in this gentleman, our long sheath is sitting in the distal aorta, hypertrophied lumbars, and a huge hypertrophied internal mammary, so inferior mesenteric artery, which is then feeding through the internal iliacs and refilling the iliac arteries. So he has got a small patent isolated segment of the left common iliac artery, Then there's an occlusion of the left distal common iliac. Both internal iliacs are patent, and both external iliacs are patent. The bottom end of his aortic bifurcation is open. So essentially, he's got an isolated aortic occlusion and isolated left CIA occlusion. So this is an interesting, nice case. It's the same one there. We're looking at this in different projections to see what is the best angle at which we can approach this. And yeah, again, my same preferred catheter, the Rubicon, with the markings down it. We managed to negotiate our way through this aortic occlusion and through the common iliac occlusion and gotten into the left external iliac. Now, again, my preference is to come, if possible, to recanalize in an antegrade fashion. That is in the direction of flow. I find it's very common when we go retrograde that I end up dissecting. And if you're going into a common iliac occlusion, trying to re-enter the aorta at the appropriate place can be difficult and can be very difficult to identify on angiogram. So you might think you've entered the aorta near the aortic bifurcation, but your entry might well be 1.5 centimeters away. In which case, getting coverage over there and getting an adequate stent and landing it in the right place all becomes quite challenging. So this has been crossed. Again, confirmatory shots to make sure you've gone through distally. Here we exchanged the wire. We captured the wire from below, brought it out in a sheath, got a vertebral up, and confirming that I am in the right space. Happy about that. So that's the left side dealt with. We still got to deal with the right side. So we plastied the aorto-iliac segment there. And this took some work for us to get back up from the right side into the same lumen to create a neo-bifurcation. This is when we're plasting the left side, make space over there for ourselves. And we finally got a window there. And often this communication through which this contrast is flowing into the opposite side is often a very tiny hole which you've got to find your way into. So the pictures often look quite nice. Reality doesn't look quite so nice. So now we've got a wire on both sides going up. Happy with that. Ready to inflate balloons over there. So ballooning both sides sequentially over here. And what we decided was we're going to create like a new aortic bifurcation. So there is something called the CERAB technique, which I will just cover briefly, where you can do that, which is nice. But what we chose, and this is again a limitation of cost and what you can do in India, is to use 2 self-expanding stents. Here, the advantage of self-expanding stents is they will have some yield within the aorta. And we all know that the distal aorta is never double the size of a single iliac. So you might ideally want to put in a 9mm stent into the common iliac, but that doesn't mean you can put in 18mm of stents into the aorta. So you need to compromise a little bit is what I think, because for me, rupturing the aorta is no fun. We really wanted to keep that inferior mesenteric in play. Got the stents in, our inferior mesenteric is running, though our stents are not as nice as they would like to because they have jumped. This is the problem with self-expanding stents. Deployment precisely where you want doesn't always happen, but we have the area opened up. Both internal iliacs, both external iliacs are running well with no real stenosis or no outflow issues over there. So would be happy with this for somebody like this. So this is the CERAB technique, which is the covered endovascular reconstruction of an aortic bifurcation. So this differs from what we have done, which is to just use 2 parallel stents running next to each other. Here they actually use 3 covered stents. This can also be called a drum in a barrel, in that you're putting in a large balloon expandable stent, deploying it about 15 to 20 millimeters above the aortic bifurcation so that you don't accidentally go into either iliac. And during the second step, the proximal part of this aortic covered stent is overdilated to completely fill out and oppose to the aortic wall. And then this is completed by getting two stents in a cross fashion, two more covered stents going in from below. So the whole thing ends up molding to each other. And this is what they say is the difference in the configuration. So when you look at a kissing stent, you have two stents which are like two ovals, which leave these gutters with poor flow, where you get neointimal hypoplasia, which leads up with longer term problems. While if you use two covered stents, both in the aortic area, you don't get any of this issue with lack of flow because your stent is well opposed to the aortic wall. And even in this area, the entire shape of your stents and the areas with poor flow are much fewer, because of which your recurrence of problems is less. Okay, so that's the CERAB technique, which is worth considering if you have a patient who can afford it. Okay, so not very different from the previous gentleman. Left common iliac occlusion, short stump, but the right side is open, no lesions over there requiring any intervention. So here we used a crossover with our favorite crossover catheter, which is a pigtail whose tip has been cut off. It works very nicely for hooking into the opposite iliac. The only thing is you can't see the tip of the pig, and if you are not careful, it's a fairly brutal catheter. So left common iliac is occluded. So we get in, and you can see the calcification in the aorta over there. I don't know why we have so many angiograms of that over here, but we do. I think the patient kept breathing. We weren't getting a good picture. We were getting gut across where we wanted to be. So ended up doing more runs than we would have ideally liked. Yeah, we were trying to look for reformation, which we were not seeing happily. So finally, with whatever images we had, managed to cross across again our favorite catheter for getting the support in, which was the Rubicon, got into the common iliac artery, and you can see the outflow is terrible. There are two skinny looking SFA and CFA down there. Got a crossover wire across. This was the supracore, I think, that we used because that's the one we like. It doesn't cause trauma distally. Angioplasty, everything starting from the external iliac artery up into the common iliac artery. Okay. And that's what it looked like over there. So then what we did was we captured this wire from below. So negotiate with a catheter, get in with a sheath and get a through and through wire, which then goes up to the top. So now I've got a wire going from the left groin up towards the heart. And we deployed a stent over here. Unfortunately, those pictures are not here. We deployed a stent and decided to do a stent protected angioplasty, which in retrospect I regret, because the self-expanding stent struts jumped out and tore the vessel. You see this really nasty bit of contrast over here. This is not nice at all. Not happy with how it looked, so looked at in other projections. You see the way the vessel is flattened out with streaking of contrast everywhere. And shortly thereafter, the man got very agitated, started jumping around on the table. First was complaining of pain, then became kind of unresponsive, which tells you he has a iliac rupture and he is bleeding into his retroperitoneum and you need to do something about it. So this is where your best friend comes in, a covered stent. We positioned it right, got the covered stent in place, got the bleeding controlled. And once this happens, you don't want to give any heparin, etc. But then once these things happen, the next level of problems happen. So now we are not seeing any flow over here distally. When we do angiograms here, this is coming from the top. The profunda flow has cut out. So an abrupt cut off of the profunda flow. Didn't like that. Weren't able to track anything across it. Finally had to lose our sheath. And and come in and do an angioplasty of the both the CFA, the SFA and the profunda. So there we were into something that we wanted to be, negotiated our way in, ballooned it up, got into this SFA here, looked distally, decent runoff there, dealt with what we had to, and managed to get a picture like that with both profunda open. There is a problem with the distal thing, and this SFA open, and no leak at the top. So when you run into trouble, other things also happen. So don't forget about trouble remote from where you had dealt with as well. Okay, so I think that's the last case. So I will just briefly, Tapish, look at those slides. There are a couple of things which I would, So these are just some of our numbers. So just to say about access, so bilateral CFA, or half the cases, ipsilateral in about 1/3, and we would take a brachial access fairly liberally, which is about 17% of the time. Stents, a lot of balloon expanding stents. This was more in the earlier days because that's the only thing that was funded by the social insurance schemes. Today, we tend to use more of self-expanding stents and covered as backup. Complications we've all had them. Embolization is the one thing I hate. There is no solution to that if it goes bad, and the ruptures, the two bad ones. Left brachial access thrombosis is one thing to be very aware of. So always check the hand at the end of the procedure and be prepared to open it up if required. Like I said, task A, C and D, access via groins, left brachial, long sheets. Don't hesitate to open the groin. Aware of embolization, rupture, brachial artery thrombosis. Never start off iliac cases unless you have some of these in your cath lab with you. And just having the stent isn't enough. You need to have the sheath which will allow you to deliver the stent over there. And if you're doing an intervention, you must have a look at the stent physically to make sure it is there. You do not want to land up in a situation where you've got to bleed and nothing to bail you out, except for a balloon. That leaves you in a difficult place. A disaster with distal trash. This was in some other case, but watch out for it. If you get a trash, what do? Aspirate out as much as you can, anticoagulate. If you have to operate, but try and get as much out as you can. And yes, pray. So we all know this, things where you go bad, where you have problems are occlusions, long lesions, atheromatous vessels. The external iliac artery is not a good artery. It doesn't like being manhandled. Stenosis does badly. Small vessels in small patients, typically women. The bigger the access sheath you use, the more problems you have. So a couple of things, make sure you have adequate access in that, make sure you have a large bore cannula available. Better off doing your iliac interventions under local anesthesia. Pain is something to watch for. If pain persists after you deflate your balloon, straight away think you've thrown something and is bleeding. Have covered stents in your lab. You have appropriate size sheets available. Confirm what's happening distally. And in the aorto-iliac segment, be paranoid. Voltaire said this, and it's very much a mantra in our lab. Getting a perfect angiogram is the enemy of getting a good patient. You're not looking at trying to get perfect images. You're trying to get good functional outcomes and be happy with that. Thank you very much.